I've decided to show a lot of images of bowel obstruction on the basis that this is predominantly a postgraduate course for practicing radiologists. So I'll be asking you to zone in fairly quickly on the abnormalities as we go, and make it pretty heavily image-linked. I would like you to understand the questions that we are supposed to be answering in obstructed bowel, to know how to read a CT scan of these patients, to be familiar with the CT findings in common and few unusual causes of bowel obstructions. And although CT is the dominant technology in the imaging of bowel obstruction, I will point out a couple of areas where other more traditional imaging studies may be used. We'll start with small bowel obstruction. And the clinician wants the answers to 5 questions really here. Is there small bowel obstruction? Is it a high or low grade obstruction? What are the level and cause? And is there ischemia? Is surgery likely to be needed? We will use almost universally now 64 size MDCT. Again, it's sometimes difficult to stop patients being given oral contrast. But if I see a physician coming through with queried bowel obstruction, I will usually get a look at the plain film of the abdomen, or if I can't get one of those, I'll have one done. If there clearly is distended small bowel, I try and stop the patient receiving oral contrast. It doesn't help, and it may actually reduce your ability to see ischemia. We use quite a high dose of intravenous contrast, standard dose really, but with a rate of about 3 cc's a second at a 60-second delay, single breath hold, narrow combination, and data reconstruction with a smooth body kernel and 1 millimeter slice thickness, and then use multiplanar workstation review for further evaluation. As we said, CT is the dominant imaging technology. It is very, very good at identifying high-grade bowel obstruction and ruling out high-grade bowel obstruction. Very occasionally you'll encounter patients with low-grade or early small bowel obstruction whose CTs appear relatively normal. A relatively normal painful abdomen, relatively normal CT, and the bowel will blow up over the next day or so. So if there's a high clinical index of suspicion, that patient may need to be followed up still. But generally, it is a reliable tool. You have to make a decision about the level of the small bowel obstruction. And to do that, the best way is to think in terms of the anatomy. We've got about 20 feet of small bowel coiled up in there, 8 feet of jejunum, 12 feet of ileum, and conceptually divide that into proximal, mid, and distal ileum. And one of the things that's a little bit tricky is, because everything's quite tightly packed in here, distended loops of proximal small bowel can flip down into the pelvis, or distended pelvic loops can flip up into the upper abdomen to find a little bit of space for themselves. And therefore, starting at the top of the abdomen and working down to try and establish where the obstruction is less reliable than beginning at the rectum and working back to the cecum and keeping working retrograde until you reach the point where the collapsed bowel gives way to dilated bowel. That's the zone of transition, and the point of obstruction is in that area. The arrow indicates an abrupt zone of transition in this patient. When you have decided where the zone of transition is, you then estimate the length of the non-distended small bowel, and you can localize it as a mid-small bowel, proximal. If it's ileal, you can say it's a distal ileal, etc. So the key is start at the rectum, work back, establish the length of the non-distended small bowel, and then apply that to your frame of reference of 12 feet of ileum and about 8 feet of jejunum. The common causes of small bowel obstruction are shown in this list: adhesions, hernias, gallstone ileus, Crohn's disease, and other inflammatory diseases such as pelvic inflammation from appendicitis or diverticulitis, intussusception, and malignancy. And I'm going to show you images from all of these as part of the process, and actually you'll be familiar with a lot of the images. There may be some that are new. Adhesions account for about half the cases of small bowel obstruction that we will see. Typically, there's an abrupt zone of transition. It may be a little less than abrupt, but the stacking or zigzagging of the small bowel in a zone of adhesions has been described. But the fundamental diagnosis of small bowel obstruction due to adhesions is based on the absence of any mass or identifiable cause at the zone of transition. It always reminds me of that old childhood rhyme the other night upon the stair. I saw a man who wasn't there again today. I wish that man would go away. Those adhesions are like that, you don't see them. There's usually a past history of surgery. This is a fairly classical and undoubted abrupt sort of transition from an adhesive band in the axial and in the coronal plane. Hernias come in various shapes and sizes. I'll show you a selection of them. We look at these inguinal femoral rictures, Lapport, pericecal, and litra, a couple of unusual causes. There's an interesting article in Radiographics in the recent past which described how to differentiate between inguinal and femoral hernias using the lateral crescent sign. This hernia is incarcerated in a hernial sac. Here we have the pubic tubercle. Here we have the femoral sheath containing the femoral nerve, femoral artery, femoral vein, and a lymph node. So the artery is lateral to the vein, there may be a lymph node. And this hernia is well medial to the femoral sheath and adjacent to the pubic tubercle. It's an inguinal hernia, and the coronal scan just shows it nicely in another plane. This elderly patient with a poor quality scan because of the bilateral hip replacements had presented with a bowel obstruction, and here we see two structures in the left femoral canal, the artery and the vein, and three structures in the right femoral canal, the artery, the vein, compressed into a lateral crescent by the femoral hernia. So this is a lateral crescent, the compressed vein. I found it useful to run the coronal images to confirm that, and be sure it's not a lymph node or something in the canal. There's the loop of bowel that we need to watch, and on the coronals, you see it coming forward, and there's the incarcerated femoral hernia. And what we want to avoid is necrosis of that. It's a very tight canal, very strong, firm ligamentous and bony structures, and femoral hernias are at risk of strangulation. And the strangulated hernia in the femoral canal that was identified by a German surgeon called Richter in the last century. He used to do not only the operation on his live patients, but he used to do post-mortems on his patients who died. An elderly lady came in under his care. He didn't make a diagnosis before she died, and at post-mortem he found that she had a femoral hernia in which a part of the circumference of the bowel wall had become trapped in the femoral canal, and that had necrosed, and the bowel wall had then fallen back into the abdominal cavity. So although these little hernias don't look like very threatening problems, this one in a laparoscopic report is potentially dangerous, because if this surface of the bowel necroses, this will then fall back into the abdominal cavity. And Richter's hernias, if you see one, they do need to notify the surgeons about them. They are dangerous hernias. Historically, they're in the femoral canal, but we've seen them more often recently in laparoscopic ports. This is a full laparoscopic port hernia. The patient developed small bowel obstruction following a laparoscopic appendectomy, and then several weeks later, presumably because the port sutures had been ruptured during the episode of post-operative obstruction, they got a herniation of loops of small bowel through the lap port, and represented with full bowel obstruction. An uncommon cause, but one you should be aware of, is the pericecal hernia. The normal anatomy is shown here with the ileocecal fold, the vermiform of the appendix, the paracolic sulci between the cecal folds. So normally the cecum is quite well pegged down there, but in certain, in a small percentage of the population, we are missing some of these folds, and that can create a gap up to a fist size behind the cecum. And sometimes then small bowel loops will herniate through that gap, what you see is when you're coming back retrogradely through the obstruction, you're traced your way back to the cecum and you suddenly see small bowel loops lateral to the cecum. You're not allowed to have small bowel loops lateral to the cecum. That's just a sagittal reconstruction. There's the cecum there and small bowel loops extending down lateral to it. That's a pericecal hernia. The only exception to that rule about small bowel loops lateral to the cecum is when the patient has previously had the cecum mobilized in the course of abdominal surgery. Or hernia, where a metal diverticulum herniates into the femoral canal and causes small bowel obstruction. So it's one of these, look carefully, you may see this only once. If you ever see it and get it right, your surgical colleagues will be most impressed. Simple diagnosis, gallstone ileus, very simple on CT. We see the laminated gallstone at the zone of transition in the small bowel. And here we see the pneumobilia from the cholecystodunodal fistula that allowed the gallstone into the small bowel. And unlike the portal venous gas that we saw earlier on, the biliary gas is in the anterior portion of the liver and centrally in the ducts. It doesn't extend out to the edge, as we saw earlier with portal venous gas. Inflammatory causes, Crohn's disease is a cause of chronic small bowel obstruction. I'm sure you're all familiar with that. This patient has uniform bowel wall thickening, transmural ulceration, dilatation proximal to this stricture in the sagittal plane. This skip vision, this segment here is followed by another stricture. That wouldn't give you any problem. Sometimes you will see small bowel obstruction in patients with pelvic inflammation. Here's somebody with an obvious significant small bowel obstruction, very decompressed colon, and when we go down towards the zone of transition, we can see the disease segment of colon, acute changes of diverticulitis, and in the coronal scan, we can see the sigmoid colon here with diverticulitis and changes around it, and loops of small bowel just plastered to the sigmoid colon of the pelvis causing the obstruction. Intussusception is really well seen by CT, has characteristic appearance. Intussusception, as you know, is like the closing of a telescope with the lead point forming the intussusceptum and going into the intussuscipiens. We see the multi-layered target with fat of the mesentery at the center, and oblique coronal planes show the abnormality very convincingly. Of course, as you know, in adults, if you have an intussusception, there is a lead point, unlike in children. Malignancy comes in three sizes, I think, in terms of small, or three shapes in terms of the small bowel obstruction. The first, not very common, is the patient who presents with small bowel obstruction who has never had surgery. And you must worry about a cecal carcinoma here. This is one such patient, moderate degree of small bowel obstruction with distension in air fluid levels, and the distended small bowel coming into this cecal carcinoma. And finally, we have endoluminal tumor. This is a genital adenocarcinoma, well seen on the axial scan, zone of transition with a bulky tumor mass. And here we have a curved reconstruction with small bowel feces, the sign of chronic obstruction proximal to the stenosing adenocarcinoma. We've dealt in detail with the question about ischemia of the bowel, so I won't go through all that again. What I will point out is this is a patient with small bowel obstruction, and we called mucosal edema in these loops and recommended early surgery. They operated and they found relatively normal distal small bowel. Again, that doesn't mean we were wrong. This patient's small bowel was congested, and the first thing to get into trouble is the mucosa. The surgeons don't necessarily see that. I'm sure the patient benefited from releasing the obstruction. Closed loop obstruction is a special case in which we have a twist in the mesentery. We have a small bowel obstruction, and on imaging we either see a U-shaped or radial appearance of the distended loops, depending on whether they're falling in plane or perpendicular to the plane. There are some signs of it, convergence of mesenteric vessels towards the obstruction, and the beak sign, or the twisting sign, of collapsed loops at the point of obstruction. What the bowel wall looks like depending on how tight the twist is. Obviously, if it is just like a tourniquet, tight enough to stop the venous outflow, but not tight enough to stop the arterial inflow, the bowel is going to get very congested. If it's really tight and the arterial inflow is cut as well, the bowel wall may look thin. This is a closed loop obstruction occurring in the plane of the scan, relatively unusual. More often it's longitudinally oriented because of the spatial issues, and what you see when the CT scanner cuts across it, multiple circular loops, which as you scan up and down, converge on a particular point or on a particular twist. And the two signs that are described are the beak sign, where the mesentery comes towards a twisted beak, or the whirl sign, where the mesentery's vasculature seem to be twisted around. This is a nice paper by Oforth et al. From European Radiology. And I was interested to see that they had actually used the vascular reconstruction package on their CT to help them make a decision about volvulus or no volvulus. And that's an option you can try as well. Is surgery likely to be needed? Well, here, obviously, if there's ischemic bowel, surgery is going to be needed. If there's a closed loop obstruction, surgery is going to be needed. But what about the patient on Thursday? This is my typical Thursday case. This patient came in on Monday. They're wondering if we list him on Friday. The small bowel obstruction appears to be due to adhesions and it's slow to settle. And what do we do here? Do we repeat the CT? Do we tell them to go away and make up their minds? That's why surgeons get all the glory. Or is there anything we can do to help them? Well, CT doesn't help that much, but a modified water-soluble contrast follow-through is helpful. It can predict the need for surgery. All we do is take 50 cc's of contrast and 50 cc's of sterile water, supine plain film of the abdomen at 4 hours. There's no significant small bowel obstruction. Things will settle if contrast is going to seek them at 4 hours. If they are uncertain, they can do a plain film of the abdomen at 24 hours, but really significant small bowel obstruction that's going to need surgery is defined by absence of contrast in the cecum. This only applies to relatively well patients with adhesions. They don't use this for patients with peritonitis, irreducible hernias, gross dilatation of the small bowel, carcinomatosis, signs of strangulation, or patients who are getting better anyway. It really is for the diagnostic, the management dilemma of wait and watch or relieve the obstruction. This is the patient we saw. The control film was there. That was the original plain film of the abdomen. And they got the gastrograph orally. After 4 hours, it's gone through to the cecum, and this patient should settle conservatively. And this other patient with distended small bowel, typical small bowel obstruction, at 4 hours, contrast hasn't reached the cecum. This patient is extremely unlikely to settle without surgery. It's a robust test, whether it's positive or negative. And the last few minutes we'll talk about large bowel obstruction. Not quite as much to say about that. One concept that I think is helpful in large bowel obstruction is the patency of the ileocecal valve. If you have got a competent ileocecal valve and you have distal colonic obstruction, you will get a very distended colon quite rapidly. If you have that situation and it is not relieved relatively soon, you will also get a distended small bowel because the small bowel contents keep coming down against the ileocecal valve, and the pressure is very high here. So we may have distended colon alone, or distended colon and distended small bowel. But don't forget, when you have an incontinent ileocecal valve, a distal colonic obstruction, your colon will not necessarily distend as much. Your small bowel will decompress it, and it's not until the small bowel capacity is reached that the colon will start to distend hugely. So you don't have to have a huge distended colon in large bowel obstruction. Here's an example. This is a patient who's got quite distended small bowel and who's got a moderately distended colon. This is a region of the ileocecal valve, and there's small bowel content, small bowel distension, moderate colonic distension. The left colon is quite decompressed, and the cause of the obstruction is a carcinoma near this metastatic flexure carcinoma in the descending colon. Again, the advantage of running retrogradely through your bowel obstructions and not solely relying on the top-down analysis. I find sometimes there's a question about large bowel mechanical obstruction versus pseudo-obstruction. Most of the time we can make the differentiation on CT, particularly with multiplanar reconstructions, because you see distension of the rectum and the sigmoid continuously. If in doubt, I would say just run some more soluble contrast up front below. And this is a more typical, the commonest cause of large bowel obstruction is going to be a tumor in the left colon. This patient has quite a distended colon and quite a typical distended small bowel, probably with a competent ileocecal bowel, which is small bowel feces, distended small bowel with the stool-like appearance in it. And there's a carcinoma there in the sigmoid descending junction, a very bread and butter case for all radiologists. And CT, very reliable both in identifying the carcinoma and, of course, in providing basic staging information. When you're looking at large bowel obstruction, I said in the first talk, always run your acute abdomens on lung windows as a matter of routine as well. You probably would spot that, but it's quite easy to miss significant cast in the bowel wall or in the peritoneal cavity. This is a patient with large bowel obstruction and a perforation. And that, of course, changes the situation, and you mustn't miss that. Sigmoid volvulus is quite classic. This is an image from a paper by Godfrey et al. I thought it was interesting because they're faced with this very distended loop, and obviously when you have a huge distended loop and you're looking at it on the CT, you think volvulus, big air fluid level. And all they did was they actually brought their CT into the 3D colonography type package that a lot of the systems have, and suddenly they've got a nice image of the classical coffee bean loop with the opposed walls, relatively apoustral apex, lower apex in the left lower quadrant, upper end below the diaphragm, and overlapping relatively non-distended colon, typical for a sigmoid volvulus. We had a case of cecal volvulus relatively recently where the ascending colon has twisted with a hypermobile cecum, and the cecum has flipped up out of here into the horizontal orientation in the upper abdomen, and is developing small bowel obstruction. Most of you would make that diagnosis on the scatter on the plain film, and there's the characteristic very long air fluid level of the cecal volvulus. And just for fun, I brought that into our CT colonography package, and sure enough, it shows it pretty well. So you can use that if you're having trouble with the volvulus, but I still think that this is the same case, the cecal volvulus case. I still think the best thing to do is go coronally and look at the vessels in the mesentery, and you will always pick up that swirl when there's a volvulus, in my experience. There's our cecal volvulus anteriorly. So I hope this has helped to understand the questions we need to answer, clarified how to read the CTs, given you some images of, in your own minds, of common and unusual causes, and we've clarified some of the relative roles of CT and other imaging studies for those indications. Thank you for your attention.